I'd like to thank the organizing committee for inviting me for this talk. These are my disclosures relevant to this talk. Just as a quick outline, I'm going to start off by talking about where the guidelines fall in the new where the cardiac devices, fall in the new guidelines. And then I'm going to talk, the bulk of the talk is going to be talking about CRT as a therapy. What is it? When is it indicated? And for which sorts of patients? And how can we use CRT and optimize it to improve patients' response? And then we're going to talk very quickly about defibrillators. Why do we need them? When is it indicated? And for which sorts of patients? And then we'll wrap up with a quick conclusion and take-home message. The main reference of this talk is going to be the latest European Society of Cardiology guidelines, which were updated in 2016. Just a tiny bit of history. Prior to these 2016 guidelines, exactly 4 years before that, in 2012, the heart failure algorithm looked like this. So you had to have a bunch of medications that you needed to prescribe for the patient, up titrate, before you even considered devices. And that was the second to last step before advanced heart therapies in terms of mechanical circulatory support and heart transplant. This is how the algorithm looks today. It's slightly similar, but there are dissimilarities in it, in that you can consider device therapy anytime along the medical therapy of these patients. But additionally, it's kept at par. CRT is kept at par with other medical therapies as well. So if you're thinking of switching a patient from an ACE inhibitor, for instance, to ARNI, you may consider offering this patient a CRT simultaneously rather than waiting for response. So just to go back to some basic concepts, the two major devices, again, as I've mentioned, I'm going to be talking about is a biventricular device, or a CRT, and an ICD. So we'll start off with the biventricular device. And the whole rationale behind establishing cardiac resynchronization therapy was that the heart function, for easiness of sake, has two major walls. You have the interventricular wall and the free left ventricular wall. And the normal pump, both of them move together in synchrony and out in systole, and out in diastole. Now, when you have, and that makes it an efficient pump. When you have a dysynchronous wall, and that is usually seen with a bundle branch block morphology or a wide QRS, that synchrony is lost. So you don't have both walls moving together in systole and diastole, making the pump not only weak, but rather inefficient. So the whole concept of implanting a CRT is that you have three leads usually, but you might have two at some stages. One is in the right atrium, one is in the right ventricle, just like a normal pacemaker or a defibrillator, and a third lead that goes through the right atrium into the coronary right sinus to the cardiac vein. And effectively, that's your left ventricular lead. So what you do is you ask your right ventricular lead and left ventricular lead to pace simultaneously, and you induce, or you force them to induce synchrony. And that's sort of the rationale behind having cardiac resynchronization therapy. Now, when is it indicated? These are the recommendations and guidelines for when to use and when not to use cardiac resynchronization therapy. And there are loads. But to make it simple, any patient with HFrEF, with an ejection fraction of less than or equal to 35%, despite good medical therapy, optimizing your medical therapy, reaching to target doses, and being on stable doses for at least 3 months, and they remain to be symptomatic, so class 2 or more, and have the best surrogate we have for dyssynchrony at the moment is the wide QRS complex. So having a QRS complex of more than 130 milliseconds. All of these patients should be considered for cardiac resynchronization therapy. Obviously, as I will mention later on, preferably if a patient has a left bundle branch block, that improves the response. Again, preferably if the patient is in sinus rhythm and you maintain your AV synchrony, that improves your response as well. But these are not by any means contraindications. The major contraindication is when you have a narrow QRS complex. So the first question that people ask, or the patient asks, is, does it really work? You know, I have advanced heart failure, I'm symptomatic, I'm miserable, and you're going to subject me to another invasive test yet again. So the answer is, this graph beautifully demonstrates the answer. When you do intervene with CRT, in the right clinical in the right clinical situation, a third of the patients are super responders. What does that mean? That means that you have a significant improvement of LV systolic function and or improvement in their functional class by more than one functional class. So going from class 3 to class 1, for instance. And then a third of the patients are responders. So responders are these patients that improve by at least one functional class and or have a modest improvement of their LV systolic function. And then in the past, we used to say a third are non-responders, but in fact, these are non-progressors. What does that mean? It means that they don't get any worse. We know with heart failure that it's a slippery slope from that point onwards. So these patients have a tendency to get worse with time. Now, if we can maintain them using a CRT in their own status quo and not to get any worse, that's a success in its own right. So CRT does work, and if you look at all of the meta-analyses and all of the studies that have been done across, historically, across looking at ejection fraction as a surrogate marker and looking at the intervention of CRT, definitely there's an improvement from baseline to 6 months post-intervention overall. Who benefits the most? Not everybody, as I said, benefits the most, but you can predict who is more likely to benefit. So the first thing, as I said, the best surrogate of dysynchrony that we have to date is your QRS duration. So the wider the QRS, the more dysynchrony, the more likelihood that they will benefit from this intervention. So again, this is based on some study, the study that looked at patients in different trials who had wide QRS complexes and their survival. The study is about 20 years old at this stage, but it definitely stands true to date. So the higher the QRS duration, the wider the QRS, the worse the prognosis. So these are one population that would benefit from CRT the most. The second one, luckily, females seem to have an upper hand in this, in that CRT seems to have a better improvement in females as opposed to men. Additionally, the morphology of that wide QRS is also equally important. So as I've mentioned earlier on, left bundle branch block, definitely patients with that fare better than the non-left bundle branch block population. But again, having a non-left bundle branch block is not a contraindication by any means. Having a non-ischemic cardiomyopathy and having a rather, lack of scar puts you at a better chance of benefiting from these devices as well. Also, there is another caveat. When we do assess response, you need to make sure that you're actually using this intervention. So you want to make sure that these patients are pacing all the time. So for you to say that you're utilizing the CRT therapy to the maximum, you need to have been pacing more than 96 or 98% of the time. And these are based on some real-world data which clearly show that close to half of our patients in the real life are not pacing most of the time, either due to inappropriate timing, inappropriate maximization of their beta blockers, or because of fast atrial fibrillation. Another thing that makes you improve your response rate is for the implanters to use the quadripolar leads. These reduce the chances of intraoperative and postoperative LV-related interventions. But not only that, regardless whether you use a CRT-P or a CRT-D, with quadripolar leads, you have reduced overall mortality, reduced cardiovascular mortality, and reduced heart failure admissions, if you compare them to the bipolar, the standard previous bipolar leads. And that's probably because you require less reintervention, you have more combinations to deal with, and also you have less anodal pacing. Now, there's never been a head-to-head analysis comparing whether CRT-P is better than CRT-D or vice versa, and that's probably because it's difficult to get the companies to do that or to sponsor that. But as a rule of thumb, what the guidelines are, if a patient is relatively sick with lots of comorbidities, maybe putting in CRT-P, especially in this health economic times, might be something suitable. If you have quite a bit of scar or an ischemic etiology, putting in a defibrillator makes more sense because these patients are more liable to sudden cardiac death. if you have a non-ischemic cardiomyopathy with a left bundle branch block, which is more likely to improve significantly, maybe a CRT-P might be reasonable. Again, these are all sort of anecdotal and never been studied and based on expert consensus. If you have more advanced heart failure, then putting in a pacing might be better. But if you have less advanced heart failure, we know these patients usually die suddenly, so they have a more propensity to developing arrhythmic deaths. So putting in a defibrillator in these cases might be a better reasonable option. A quick word on atrial fibrillation. Again, you will benefit the most from CRT if you make sure that you are pacing all the time. So although it's not a contraindication, but if you fail to pace all the time because the patient has likelihood to go in fast Afib despite good medical therapy, you may have to resort to AV junction ablation, AV node ablation, and induction of complete heart block, and thereby enforcing the patient to pace all the time. So where does this fit in the guidelines? The guidelines say if you have symptomatic patients with HFrEF, give ACE beta blockers, mineralocorticoid receptor antagonists. If they still are bad, look at their QRS along with other things, and if the QRS duration is wide, consider putting in a CRT. So if the patient is not a candidate for CRT, is there anything else we can do for these patients? And the answer is yes. Going back to basics, heart failure confers quite a high mortality. About 50% of these patients die within a year of diagnosis. And a lot of these deaths are attributable to sudden cardiac death or ventricular tachyarrhythmias. So if they're not a candidate for CRT, putting in a defibrillator and minimizing that cause of death can, in the long run, improve your outcomes. So when is an ICD indicated? As per the guidelines, you have two major indications, secondary prevention and primary prevention. In terms of secondary prevention, it's pretty easy. So if you have a patient with left ventricular dysfunction and evidence of tachyarrhythmia in the absence of reversible causes and is expected to survive beyond a year, then you should be considering them for defibrillators. In terms of primary prevention, that's a different ball game. So in here, basically, if you have a patient with heart failure and reduced ejection fraction, you've exhausted all of your medical therapy, yet they remain to be symptomatic and have a narrow QRS complex, so you cannot offer them CRT, you should be thinking about an ICD if they have a relatively good functional capacity and reasonable prognosis. Again, who benefits the most? Patients who have scar because of an underlying ischemia have more likelihood of dying of an arrhythmic death, and therefore they're the ones who are most likely to benefit from the ICD. And that was challenged as well by the Danish trial, which was published exactly 2 years ago, which basically said, we know that ICDs work fantastically well in ischemic cardiomyopathy, but have we ever really looked at it in the non-ischemic group on its own? And they looked at this, and they sort of had a randomized study, one-to-one fashion between good medical therapy versus an ICD plus good medical therapy. And it didn't have any clinical significance between the two. It was a neutral study with no added benefit of ICD in the non-ischemic cardiomyopathy group in terms of the primary outcome, which was death from any cause. But if you look at the group dying from sudden cardiac death, there was a definite improvement and an edge of putting in a defibrillator, which is the reason why we do that in patients with non-ischemic cardiomyopathy. And a few months after that publication, which caused a lot of angst and people were worried about changing the practice, this was published in Circulation. And it was basically a review of all of the non-ischemic cardiomyopathy groups within all of the major device studies. And almost all of them, regardless of where you were, had a favorable outcome with the implantation of device, and they all crossed the line of unity in favor of device therapy. So as we stand today, it may change later on, but as we stand today, the data in favor of what has been said in the guidelines stands corrected. So we should be considering it in the non-ischemic groups as well. So the ICD therapy in the guidelines is actually, you can use ICD anywhere along the guidelines, specifically for patients with secondary prevention heart failure. Just last slide. So in summary, dear chairpersons, dear colleagues, cardiac devices are an integral part of management which is underutilized. Optimal medical therapy with good medications at good doses is the first step. If you have a low ejection fraction and remain to be symptomatic despite optimal medical therapy, you need to ask yourself two questions. What is the QRS complex duration, and what's the prognosis? If it's wide, think of CRT. If it's narrow and good prognosis, think of defibrillator. Thank you very much.